Hi everyone, my name is Morgan from the New England QIN-QIO, and I'd like to thank you for joining us for the 5th New England QIN-QIO Healthcare-Associated Infections Collaborative Webinar on an overview of VAEs. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. I'll provide you details with accessing that at the end of this webinar. The phone lines are on mute for the duration of the presentation. We will be taking questions at the end, and I'll give you instructions at that time on how to unmute your line. For those of you interested in CEU credits, we will be offering 1 credit for this webinar, and upon completion of the webinar, you will receive an evaluation, so you must fill that out in order to get your certificate for credit via email. So I'm going to pass it over to Carol to introduce us to our speaker.
Good afternoon, everyone. I'm Carol Dietz. I'm one of the QI consultants here at Qualidigm, which is the Connecticut portion of the New England QIN-QIO. I'd like to introduce Dr. Mark Metersky, who has been a practicing pulmonary and critical care physician for 23 years and is professor of medicine and director of Center for Bronchiectasis Care at the University of Connecticut School of Medicine. He has published extensively on the subjects of pulmonary infections, performance and measurement, and quality improvement, and is a frequent lecturer at national and international meetings on these areas. He served on the technical expert panel for the Centers for Medicare and Medicaid Services National Pneumonia Project and has worked as a consultant in these areas with Qualidigm for over 10 years. And more recently, as Qualidigm's clinical lead for the Agency for Healthcare Research and Quality Medicare Patient Safety Monitoring System, which we love to call MPSMS. He has also served on the Quality Improvement Committee and is the immediate past chair of the Guidelines Oversight Committee for the American College of Chest Physicians. He is a member of the Executive Committee of the American Medical Association's Physician Consortium for Performance Improvement. So, without further ado, I would like to turn the presentation over to Dr. Mark Metersky. Mark, the microphone is now yours.
Well, thank you, Carol, for that nice introduction, and I'd also like to add my welcome to everybody. And I'd like to jump right in because we have a lot to cover, and I'd like to make sure that we have some time for questions at the end. So we're going to talk about VAP and the new paradigm, VACs and IVACs, and maybe address some of the anxiety that some people are certainly feeling about this new paradigm. I'd like to cover several aspects today. First, I'd like to review the pathophysiology of VAP. I want to review strategies for preventing VAP, including those that are recommended by IDSA-SHEA, those that are not routinely recommended, and some that weren't addressed but may be relevant to certain practices. And then I'm going to switch gears and review the new paradigm of VACs, including the definitions, the rationale, and present some evidence regarding the usefulness of this new paradigm. Why do we care? Well, it's a big problem. There are up to 300,000 episodes of HAP and VAP per year in the United States. Data that we published in the New England Journal from Qualidigm from that MPSMS suggests that approximately 10% of ventilated patients are affected. The crude mortality is up to 40%. That means that if you get VAP, you have about a 40% chance of dying, but we know that patients who get VAP are often critically ill, and most of those patients are not actually dying from the VAP, they're dying of their underlying illness. But the attributable mortality, those that are actually dying from the VAP, although controversial, is probably in the 13% range. However, there's no controversy regarding the effect upon ventilator days, hospital length of stay, and cost. That clearly affects all these metrics in a big way. And these are the patients we're concerned about, right? The patients who are critically ill, very vulnerable, very high tube-to-orifice ratio, which, as we all know, is a huge predictor of bad outcomes, especially when some of those tubes are in orifices that didn't previously exist. We've all seen these types of patients. How does that happen? the answer is pretty simple. Essentially, all VAP is aspiration. Bacteria get into the lungs from the stomach, from the nasopharynx, from the oropharynx, from the ventilator circuit and the ET tube. Anyone who's seen disgusting ET tubes after they've been removed is easily convinced of that. And also from the subglottic secretions, the pool of really disgusting infected material that accumulates above the cuff of the endotracheal tube. Prevention of VAP is therefore based upon preventing these bacteria from reaching the lung. Conceptually quite simple. And how can we do that? We can decrease the risk for colonization of these areas. We can remove as much of the colonized secretions as possible, so we lower the chances of them getting to the lung. And we can decrease the risk of bacteria which are present from reaching the lung. And we'll talk about preventive measures that address each of these three aspects. Well, although it won't improve your publicly reported metrics directly on VAP, if you prevent people from getting ventilated, it's certainly safer for your patients. You can't get VAP if you're not on a ventilator. And certain things can be done to keep people off ventilators. One is an appropriate preoperative evaluation for patients who are at risk of respiratory failure, especially those who are undergoing elective surgery. It is not infrequent where we see people who have major surgery and they just haven't had a preoperative evaluation to assess risk and perhaps make suggestions. In addition, there are a large population of patients with respiratory failure who, in general, will do well with non-invasive ventilation. Three of the classic underlying conditions are COPD, CHF, and neuromuscular disease. And this is a study from the New England Journal. It's quite old, but it clearly established that non-invasive ventilation has benefits. And you can see I've highlighted the pneumonia outcome, and only one patient had pneumonia in the non-invasive ventilation group, and in the conventional ventilation, 8 patients. So a clear difference that was statistically significant. In addition, the longer a patient is on the ventilator, the greater the risk of ventilator-associated pneumonia. Each extra day increases the risk. The magnitude of that increase has changed over time, so I didn't give a specific percentage, but it's clear that that's the case. One of the important things we can do to minimize the length of time on the ventilator is use sedation appropriately. Minimize sedation wherever possible, and using use of the short-acting sedatives that when we turn them off, they go away quickly. We'll talk a little bit about daily sedation vacations. One thing that has not been proven to have benefit that we used to think might be a promising way to shorten the time on the ventilator was early tracheostomy. Initial studies looked promising, but subsequently were not borne out. So we do not recommend early tracheostomy, at least specifically for decreasing the length of time on the ventilator. Daily interruption of sedation has been shown to be quite useful for a lot of reasons in patients on the ventilator. This is one of the earlier studies also from the New England Journal 15 years ago, and it showed that the intervention group, the pure intervention was just waking them up once a day. And as you can see, they got off the ventilator much quicker if they had that intervention. By itself, that is effective, but it's even more effective when the daily sedation vacation is linked to a daily assessment of readiness to wean. So not only waking up the patients, but in a protocolized fashion, checking to see if they're ready to make strides to coming off the ventilator. And over the years, I've seen innumerable patients where on the face of it, superficially, the patients did not look like they were ready to wean, to be removed from the ventilator. And without a protocol, no one would have checked. They would have not come off the ventilator. Yet, to our surprise, for whatever reason, they were better off than they looked. And only because assessment of their readiness to wean was protocolized did we discover it on that day. So that's a very important part of the sort of dual intervention of the daily sedation vacation and the daily assessment of readiness to wean. And you need to protocolize it. If it's not done in a protocolized fashion, it doesn't happen in a reliable way. And this is a meta-analysis of several studies that looked at this issue. And as you can see, the overall pooled results showed a significant, when this diamond at the bottom of the meta-analysis doesn't cross the zero line, then it's a statistically significant improvement. And as you can see, daily assessment, oh, I'm sorry, I take it back, wrong slide. This is non-invasive weaning from the ventilator. In these studies, what they did is they took patients who weren't ready to wean yet, and they weaned them onto BiPAP. And what they showed is that you can decrease ventilator days that way, and presumably that would decrease ventilator-associated pneumonia. And sure enough, here you also see that this diamond does not cross the line of unity. So in selected patients who may not be ready to come completely off assisted ventilation, but may be stable enough and close enough that they would tolerate BiPAP, you can consider weaning them onto non-invasive ventilation. Early mobilization can also help you. I think it's fair to say that the mechanism for early mobilization affecting ventilator days is not completely clear, but several studies have shown benefit. I think it's possible that one way it does it is that the mobilization itself doesn't improve the patient's ventilator readiness to wean directly, but it certainly forces the caretakers to minimize the sedation and puts more attention on freeing the patient from the ventilator. As you can see in this study, ventilator-free days were increased in patients with early mobilization. Duration of mechanical ventilation also decreased 3.4 days versus 6.1 days in control. You can see a little note of caution is that the major decrease was in non-survivors. So control non-survivors stayed on the ventilator about 10 days and 2.5 days for the intervention group, whereas the difference was not quite as great on the survivors. So it suggests that the mechanism is not completely clear, but there seems to be a benefit of early mobilization. This you're not going to find in the IDSA SHEA guidelines. It's older literature, but I think it has some relevance. Nasogastric tubes and nasotracheal tubes increase the risk for bacterial sinus by impairing drainage of secretion from the sinuses. Therefore, they make patients more prone, more at risk for developing bacterial sinusitis. And as you can imagine, especially in a patient who's ventilated and sedated, who cannot clear secretions well, if they have pus in their sinuses that's draining, it may drain into the lungs, and which would obviously be a risk for ventilator-associated pneumonia. This study, referenced below, was a randomized trial of oral versus nasal tracheal intubation. And with this study, what they found was decreased incidence of sinusitis, VAP, and length of stay with the oral tracheal intubation. All these approached but did not quite reach statistical significance, as it was not a huge study. So what to do with that information? We don't, in our ICU, we do not intubate anyone nasally, and I think that's standard practice based upon these data. What may not be as standard is that we almost never put in nasogastric tubes. We put in orogastric tubes. We understand that it's not ironclad, that it prevents ventilator-associated pneumonia, but we feel that there is some evidence to suggest benefit. In addition, it's less risky and causes less discomfort for the patient to slip a tube down the mouth alongside the endotracheal tube than it does putting it through the nose, where these patients who may be thrombocytopenic or on anticoagulants are prone to nosebleeds. So that's our practice. It's essentially risk-free, probably avoids risk, and may also decrease the risk of ventilator-associated pneumonia. A lot of the interventions that we pursue are related to the so-called gastropulmonary route of infection. And this is the theory that colonization of gastric contents with pathogenic bacteria results in oropharyngeal and then airway colonization, leading to ventilator-associated pneumonia. As you can imagine, if the bacteria get up into the mouth, they can then reach the lung by gravity, or if the patient vomits or secretions pool just because the patient's prone, again, bacteria can get into the lungs. The first question is, does this concept really exist? There's no doubt, however, that increasing stomach pH results in higher bacterial concentration in the gastric fluid. That's one of the reasons for gastric acid is to protect the gut from colonization with pathogenic bacteria. And critically ill patients are prone to increases in the gastric pH for a lot of reasons. Just being critically ill by itself inhibits stomach function, including secretion of acid. And in addition, many patients receive pharmacologic gastric acid suppression, these days mostly with proton pump inhibitors, but also H2 blockers, and not so much antacids anymore. Finally, enteral feeding increases gastric pH, allowing bacteria to grow. One of our fellows here did a study which showed that quite nicely, that the enteral feeding increased pH and increased the number of bacteria we could grow from the gastric juice. And that feeding intermittently allowed the recurrence of an acid environment and allowed decreased colonization. And we talked about doing that, but it wasn't something that we implemented routinely, but it does illustrate the concept that there are a lot of things that we do that promote bacterial colonization of the stomach. Now, how important is this concept? Several studies have shown that about 30% of patients who developed colonization in the respiratory tract, so in the trachea or the lower airways, the same organism was first present in the stomach. It depends upon the organism. It's more frequent with E. coli and other enteric gram-negative bacilli, which makes sense because they live in the gut. Pseudomonas, which is not really a gut organism, but is one of our more feared bacteria with respect to ventilator-associated pneumonia, actually was not prone to this issue, as it more commonly appeared first in the trachea and the oropharynx. So we're not going to prevent Pseudomonas pneumonia, unfortunately, by addressing this issue. Now, one way, at least in theory, that we could minimize bacteria and stomach contents from getting into the lungs would be by using small bowel feeding versus gastric feeding. So this is by putting in a small bore tube or a gastric tube that bypasses the pylorus and its tip is in the duodenum instead of in the stomach. And therefore the stomach remains more empty with less volume and potentially more acidic pH. And this meta-analysis shows that patients had a lower risk of VAP if they received small bowel feeding as opposed to a tube that just ended in the stomach. In addition to that, though, are other concerns, and that's the concern with resource use. It's sometimes tough to get these tubes post-pyloric, so patients end up sometimes having to go to radiology, although not always. And therefore, that's somewhat limited the uptake of this intervention. But in some ICUs, it seems to be somewhat cultural. In some ICUs, this is something that is considered very important, whereas in many ICUs, it's not thought to be something important, perhaps because although it's been associated with lower VAP rates, it hasn't affected other outcomes like patient mortality. But if you're in an ICU that has trouble with VAP rates, it's something to consider. How else do we keep the stomach contents out of the lungs? Well, we're all aware of the positional issue and 30-degree head of bed. It all started with this study back now 23 years ago out of Spain. And this study, they weren't looking at VAP, but they were looking at an indicator of stomach contents traveling into the lungs. And what they did is they put some radioactivity into the stomach contents, and then they measured how much of it got into the lung. And as you can see here, if they were supine, if they were supine, a lot got in, and if they were semi-recumbent, and in this study I believe it was 30 degrees, much less radioactivity, indicating much less volume of stomach contents got into the lungs. This prompted a randomized trial from the same group, although different first author, and they looked at 0 degrees versus 45 degrees. And they found pneumonia in only 8% of the patients who were kept at 45 degrees, and 34% in patients who were kept supine. They also found that this effect was most relevant, most important in patients who are receiving enteral feeding. Again, that would be potentially more support for considering small bowel feeding. However, the next study looking at this didn't have quite so rosy of an outcome. Very similar study design, except the control group was at 10 degrees, not 0 degrees. And as you can see, there were no statistically significant differences in the percentage of VAP. As a matter of fact, the percentage of any other important outcomes, ventilator days, VAP, hospital stay, etc., nothing was improved in the patients who were sitting up. So why do we see discordant results between those two studies? Well, perhaps 10 degrees is as good as 45 degrees. It's a theory. We have no way of knowing. Perhaps it's important that the second study, they only achieved 22 to 28 degrees. Perhaps 45 degrees is needed. So they were aiming for 45 degrees, but they didn't achieve it. And I think that's something we can all commiserate with. It's very hard to keep a patient at 45 degrees. They tip over, they slide down, etc. Other possible explanations is related to the conduct of the study. The first study excluded patients with prolonged deviations from the appropriate position, which sort of had the effect of exaggerating the results, because we know that we're not always going to be able to keep patients upright for many reasons. In addition, there was a low overall rate of VAP in the second study, which really limited the statistical power to detect a difference. One thing that's important to note is none of these studies were 30 degrees. And we don't have evidence for 30 degrees. So if we're going to do it, we should probably try 45 degrees, even though the quality measure is 30 to 45 degrees. But we should be aware of the underlying evidence and keep that in our minds as we go about these interventions. This is another issue which did not make it into the SHEA IDSA guidelines. They accurately state that stress ulcer prophylaxis, even though it's part of the VAP bundle, they state it should not be used to prevent VAP. And they're, of course, absolutely right. Stress ulcer prophylaxis doesn't prevent VAP, it's to prevent stress ulcers. And, of course, that does not address the issue of which agent to use if prophylaxis is going to be used. And there's a long history of experimentation looking at VAP in relationship to the use of sucralfate, which coats erosions in the gastric mucosa, but does not raise pH, versus the use of antacids or H2 blockers or PPIs, which raise stomach pH. These studies had conflicting results, but when meta-analysis was done, where they pooled the results from all the studies, 4 showed statistically significant decreased rates of VAP with sucralfate, whereas 3 showed non-significant trends toward decreased rates of VAP with sucralfate. And this is potentially important. Again, as we've seen with other interventions, the effect on VAP was greater in patients receiving enteral nutrition. And I need to make you aware that the usefulness of routine stress ulcer prophylaxis is being questioned. And that may be a more important concept to address in your ICUs than which one to use. The pendulum is certainly swinging on stress ulcer prophylaxis, so that it seems that a fair number of patients who are getting it probably do not need it, as the rate of stress ulcer bleeding seems to be declining in critically ill patients. And this is another meta-analysis looking at H2 blockers versus sucralfate. And as you can see, it's on this side of the line, the diamond, and it does not cross the line, and there's a statistically significant but not huge benefit of using sucralfate versus H2 blockers for stress ulcer prophylaxis in terms of the outcome of ventilator-associated pneumonia. So how do I summarize all that data and what to do about it? There's probably a small but real effect in diminishing the rate of VAP relative to H2 antagonists and PPIs with the use of sucralfate versus these agents that increase gastric pH. The mechanism may be due to preservation of the acidic pH that kills organisms, or a direct antibacterial effect of sucralfate, which it has a very small antibacterial effect. If this is something that resonates with you and you're going to consider it, you need to be aware that sucralfate may be associated with a slightly higher risk of upper GI bleeding or stress ulcers than H2 blockers. So this recommendation, which does not come from IDSA, this is purely my opinion, is that you can consider the use of sucralfate instead of H2 blockers or PPIs in ventilated patients, except when there are specific risk factors for GI bleeding. I think while it's my opinion, it's an opinion that's based on evidence, and it's certainly shared by some other people. I'm not going way out on a limb here. The next method of preventing bacteria from reaching the lung is subglottic secretion drainage. And for those of you who may not be familiar with it, this is a variation of the usual endotracheal tube, which has just 2 lumens, 1 lumen for the cuff, to blow up the cuff, and of course the lumen that the air is delivered, the gas is delivered through, and there's a 3rd lumen here. And that's connected to a port here where that disgusting collection of fluid can be sucked out, so that if the cuff becomes slightly deflated or is deflated on purpose for checking cuff pressure, we don't have a pool of bacterial secretions that fall into the lung. Many studies have looked at this, and the results are pretty clear, that the use of subglottic secretion drainage decreases VAP rates by about 50 to 60% on average. Again, there seems to be a variable effect on different types of organisms. Unfortunately, again, little effect on Pseudomonas or gram-negative enterics. More of effect on the bacteria that commonly reside in the oropharynx. In addition, there were lower ventilator and ICU days associated with subglottic secretion drainage. Unfortunately, mortality was not affected. And that may be, again, because the most pathogenic, the most worrisome organisms didn't seem to be affected. That from those organisms had similar rates, with or without this. It's my impression in talking to colleagues that while many ICUs do use these special tubes and perform subglottic secretion drainage routinely, many do not. And I think it's worth asking the question, why not? Why has there not been a wider uptake? Well, one reason is the cost of the tube, I think. It's significantly more expensive. Now, if you're going to only use the tube in patients who had prolonged ventilation, it wouldn't be that expensive. But, of course, you don't know for sure when you intubate a patient how long they're going to be intubated for. And so what it means is putting in these tubes in a lot of patients who may not need them. It also means keeping them on all the code cards, because those are the patients, obviously, that have a high likelihood of prolonged intubation. And these tubes often expire and need to be replaced without ever being used. One thing that you should not do is extubate patients who've been intubated with a regular tube who end up staying on the ventilator longer than you expect to put in one of these tubes. The risk of extubating and reintubating is not thought to be worth the potential benefit. The SHEA IDSA recommendations are to use these tubes in patients who are likely to have prolonged intubation, which they identify as 48 to 72 hours. And as you can imagine, even though the tubes are more expensive, if they're used judiciously and you're able to hit the right population, then they may nonetheless be cost-saving. Because, of course, as we talked about in the very first slide, VAP is very expensive. I also wanted to spend some time talking about interventions that are not recommended for routine use by SHEA IDSA, but nonetheless might decrease VAP rates. And I am in no way disagreeing with SHEA IDSA, but for ICUs that are having specific problems with VAP rates, these are something that could be considered. And these are the 4 interventions, and because we have time, I will go into them. I was going to include these slides even if we didn't have time to talk about them, because I knew that everyone would have access to the slides and therefore would be able to get more detailed information. So the first one is the Silverimpregnated endotracheal tube. Why silver? Because silver has antibacterial action. It inhibits bacterial growth. The first study had some limitations. Nonetheless, it was good enough to get into JAMA. It was not blinded. There was just by chance excess COPD in the control group, making them at higher risk for VAP. They had much lower rates of VAP than they expected, so their statistical significance their ability to get statistical significance was somewhat limited. And perhaps not surprisingly, they showed no decrease in length of stay, days of intubation, or mortality, although VAP rates were decreased. They did not measure antibiotic use. They did look at cost. The tubes are expensive. The number needed to treat to prevent 1 case of VAP in this study was 37 patients. Getting a tube, 1 case of VAP prevented, which adds up to a fair amount of money, but is certainly a lot cheaper than VAP. So SHEA IDSA, because there were no patient-centric outcomes like length of stay, days of intubation, mortality that were improved, say that these are generally not recommended. And this is the study in which you can see that the uncoated tubes, patients with uncoated tubes had a higher rate of VAP and developed VAP sooner than the patients who received the intervention. Chlorhexidine oral care in cardiac surgery patients. Why do I say cardiac surgery patients? Well, because as you'll see, that's where the evidence is. The evidence for preventing VAP in other types of patients is much more limited. This is one of the first studies back from 2009. They compared experimental group was chlorhexidine oral care versus a control group with usual care. And you can see there were fewer infections, fewer respiratory infections overall, as well as fewer other infections in patients who received the chlorhexidine oral care, including lower respiratory infections, which are pneumonias. And if you pooled all the respiratory infections, it was statistically significant. Chlorhexidine has been extensively studied in dental and hand-washing literature. It's safe, it's effective, it's inexpensive. There are no apparent issues of resistance. Several studies, in addition to the one I just showed you, demonstrated lower rates of VAP and other nosocomial infections with chlorhexidine mouth care. A meta-analysis pooling these studies demonstrated a clear-cut effect on VAP only in cardiac surgery patients, and a borderline or possible effect in non-cardiac surgery patients. Other information that may be relevant is that a foam swab, as opposed to a toothbrush, may be less effective, although admittedly there are conflicting results on this issue. And IDSA Shea say or chlorhexidine oral care may lower VAP rates, but insufficient data to determine impact on duration of ventilation, length of stay, mortality. So they don't specifically recommend it. My feeling is that oral care is important, if for no other reason than aesthetics. Patients and family members, the patients probably do not like having all that debris that accumulates in their mouths when they're intubated. Family members definitely are bothered by it. It's not unusual for a family member to complain about all the white, disgusting stuff in their family member's mouth. So we're going to do oral care anyhow. And to me, it makes sense to use chlorhexidine if we're going to do it. Selective decontamination of the digestive tract. This may not be familiar to all of you. However, it is commonly used in other parts of the world, especially in Europe, where there have been a lot of studies and meta-analyses with overwhelming evidence of significant decrease in the rate of VAP. And as I said, it's frequently used in Europe and has not been adopted much in the U.S. Variable results as to whether the benefits are as significant in medical versus surgical patients. Some meta-analyses actually show mortality benefit. The techniques vary. Basically what this involves is exactly what it says, is trying to remove bacteria or prevent bacteria from growing in the digestive tract, starting at the mouth and going into the gut. And the techniques vary, including oral versus oral and gastric, topical non-absorbable antibiotics, or even using a brief course of IV antibiotics. It is of note that the studies which used these IV antibiotics are the ones that showed the reduction in mortality. The other studies with just the topical non-absorbable agents did not show that. So why don't we use that in the United States? There's concern about cost due to the cost of the antibiotics. There's concern regarding resistant organisms being selected out by the use of antibiotics. So some people would say indiscriminately or frequently, and certainly we need to worry about C. diff. These trials were almost all done in Europe, so there may be some parochialism that we don't accept things that are done in Europe or less likely to be aware of them. So I'm not exactly sure, but these are probably some of the reasons. And the guidelines state that there are insufficient data on possible risks to allow them to recommend this, while acknowledging that they do prevent VAP. And I think that's fair. I'm certainly not recommending STD, but I think it's important for people to be aware of it. So that's a quick run through of the major interventions to prevent VAP, both those that are strongly recommended by Shea IDSA, as well as some other ones that may be relevant in particular situations. But it does bring us to how we get these interventions implemented in a reliable fashion. Do we trust the house officers to write them every time? I don't. Do we trust the attendings to write it every time? I don't for that either. I don't trust myself to write them every time. What we need are protocolized, systematic ways that for every patient, these things get either addressed or provided, or at least the appropriate consideration is given to using them. And even appropriate consideration may not be enough, because we all know that people may consider things but not do them for the wrong reasons. So I think that for any of these interventions that you want implemented in a systematic way in your ICU, they need to have pre-printed orders or protocolization for the more complex ones, like the assessment of readiness to wean. And these include oral hygiene, bed position, etc. That's not quite enough, though. You then need to monitor adherence, see how you're doing, find out why you're not doing well if you're not, and then change your system, provide feedback as necessary to ensure optimum adherence. Now I'm going to switch gears and get to the newer issues. The newer issue of the change in our surveillance definition of VAP into quite a different paradigm. Well, what prompted the change? First of all, why do we need a new definition? Well, because the old one was not good. It may work clinically, but for surveillance, it did not work. It was not reliable, meaning that if two people looked at the same patient, one might say VAP and the other one might not say VAP. It was not valid. So if two people looked at the same patient and said VAP, and then did an autopsy on that patient, very often that patient would not have VAP, or vice versa. If two docs looked at this patient and said they don't have VAP, and you happen to have an autopsy, they might have VAP. So it's not accurate. Even more important, potentially, it's subject to incredible bias. These are some of the elements that you're probably all familiar with. Increased sputum volume. Two people can look at the same patient and say, well, yeah, maybe a little bit, but not enough to be sure that it's increased volume. And whereas someone else might say, yes, there's a lot more sputum here. And so unconscious bias can affect it. And purulence, worsened oxygenation, is it really worse or is it only slightly worse? Change in lung exam, altered mental status. Again, they're very squishy endpoints, and they're very subject to bias. So this may lead to unconscious bias or conscious gaming that may not be detectable. And differences in rates across providers may not be due to real differences in their outcomes, the outcomes of their patients. They may just have different lines for when they define something as VAP, or when how they define the underlying criteria like increased sputum purulence, et cetera. And as I alluded to, if you do a study looking at the agreement between different adjudicators for the diagnosis of VAP, you find a high level of disagreement. So this is the situation we're in. We have a lot more tests to go through before we can say for certain we don't know. What's embarrassing is that as a pulmonologist, I can use this slide for just about every talk. Pulmonary embolism comes to mind in addition to pneumonia. So our new paradigm are the ventilator-associated conditions, VACs. The putative advantages are the definitions are objective and therefore not as prone to bias. They're likely reliable, meaning that two different people looking at the same patient will agree on these criteria. The level of validity, to be fair, I have to say we have some evidence for it, and I'll go through it. But I think we need more data to know how valid these definitions are, meaning how accurately they reflect what's truly going on with the patient. So we'll go through them, although I'm sure you're all very familiar with them. What is a VAC? A ventilator-associated complication. An increase in daily minimum PEEP greater than 3 centimeters of water, or an increase of the daily minimum FiO2 greater than 20% for at least 2 calendar days in a patient who is stable at baseline, with the definitions of stability there for you. Now, an IVAC is a patient who has a VAC who also has evidence of infection. So an abnormal white blood cell count, hypothermia, fever, and they have to be linked in time within a few days of each other. And they had to be significant enough that a physician prescribed antibiotics, because some patients have fevers for reasons that are thought not to be due to antibiotics. And finally, VAC, with the new definition, is an IVAC plus some evidence of infection. And there are multiple different ways to meet the definition of infection, including quantitative cultures, a positive culture that is only semi-quantitative, or some people will call it qualitative, with purulent sputum, or non-culture evidence of infection, such as urinary antigen, pathology, or DNA amplification. The rationale, in addition to what we discussed about the concern for bias and reproducibility of the old definition, is that if we're going to take a holistic approach and try and improve all aspects of patient outcomes, VAP isn't the only bad thing that can happen to a patient when they're on a ventilator. It's an important one, but other things are atelectasis, pulmonary embolism, worsening lung injury, due to non-adherence to protective lung ventilation, so a low tidal volume strategy, iatrogenic fluid overload, prolonged ventilation due to excessive sedation. These are all things that are potentially avoidable, and surveillance for VAP only misses these important adverse events, and so that's part of the rationale for expanding the conditions that we surveil for through the use of these non-infection-related overall VACs. Now, this study looked at the issue of how close is a VAP to a VAC to an IVAC. And as you can see with these Venn diagrams, VAP only and VAC only was most of them. So the overlap here is just a small percent of the patients who will have both a VAC and a VAP. And critics of this new paradigm have shown this and said, see, it's not relevant. VAC is not important. It doesn't represent VAP. And to a certain extent, yes, it doesn't represent VAP because it's not meant to. But in addition, we also know that if we did the same Venn diagram with VAP from Dr. 1 and VAP from Dr. 2 here, there'd be a similar amount of patients who are in only one and the other without overlap. So I think that criticism that it isn't VAP, while true, is sort of beside the point. The next important thing to know is, does it matter to patients? If patients with VACs or IVACs do just as well as patients who don't get them, then we're surveilling for something that's irrelevant and we're wasting our time. But they are important. So here's length of stay in a patient with an IVAC versus non-IVAC, more than twice as long. That's ICU length of stay. Hospital length of stay, 12 days longer. Duration of mechanical ventilation, 10 days longer. 8 days or 9 days almost of antibiotics excess, and hospital mortality is higher. And if you compare it to VAP versus non-VAP, it seems that these events are more important. Yes, VAP has a longer length of stay than non-VAP, but the difference isn't as much for IVAC. Length of stay is pretty close. Duration of mechanical ventilation, the excess is more for IVAC than it is for VAP. Antibiotics are similar. Mortality, interestingly, in VAP versus non-VAP, unchanged, but IVAC higher. So this would suggest that IVACs are important and perhaps even more important than our standard definition of VAP. The other thing that we need to know before we can say it's important to surveil these things in terms of quality improvement is, can they be prevented? And we have a little less evidence for that. This is one study that looked at 67 looked at 1,200 patients, and they detected 67 VACs, prospectively, of which half were IVACs. And about half of them were deemed preventable. But I would say that this is not the best evidence because they define VAP as preventable by study definition. And many of these preventable ones were VAPs. Other causes they saw for VACs were ARDS and infection or inflammation from elsewhere besides the lung, whether it be a UTI or pancreatitis or something like that. This is another study looking at this new paradigm and the potential preventability. What they did is prospectively they put in place protocols and mechanisms to improve the performance of all the components of good VAP prevention. And on the right-hand axis, you can see the percent adherence over time. It started at around 44%, and then in 24 months, it went up to 55%. So not a huge increase, but clearly an increase. And as that happened, what you can see is that VAP rates went down or trended down, as did VAC rates, which is the middle bar, but IVAC actually went up. So it's hard to know for sure how preventable these events are based upon the data we have to date. This study didn't prove preventability, although it suggested that at least VACs got better, but IVACs didn't. But then again, their percent adherence only increased a little bit, from 44 to 55%, which may have limited their ability to detect an improvement. So we come back to that original patient with all the tubes, and I flashed by it quickly, but I wanted to see if you noticed all the things that were being done wrong, although not really. We staged this. She's using a swab and not a toothbrush. The patient is supine, not sitting up. There's an NG tube that's sitting next to his nose. It's not really in him. And there's another one which perhaps only a few of you may have recognized, but the sink in this ICU was designed in the back, which is the last place you want a sink if you want people to wash their hands, because you have to walk all the way around the bed to the back of the room to get to it. So this patient, at least pretend, was not getting the best care except for the sink. That's real. To summarize, here are the recommendations that are in the guidelines for prevention of ventilator-associated pneumonia. Avoid intubation if possible through the use of non-invasive ventilation. Minimize sedation, use short-acting sedatives, and link the sedation vacation to assessment of readiness to wean. Early mobilization, subglottic secretion drainage, and despite the weak evidence, elevation of the head of the bed, because obviously it's a low or no cost and low or no risk intervention. I'll parenthetically tell you that logically, an even better way to keep some of the contents out of the lungs would be 100% time for the patient in Trendelenburg with the head lower than the stomach. We don't do that, but there is some evidence that actually is better than head of the bed up. We just don't know how well patients will tolerate that long term, but if you think about it, it makes more sense than what we're doing now. And with that, I think we have time to open it up for a few questions.
Yes, that's correct. Thank you for that wonderful presentation. It appears there have been no questions in chat, so if you have a question, please press *6 to unmute your line and ask your question.
Dr. Metersky, I have a question to start us off. Back in the beginning of your presentation, you talked about the daily assessment, readiness to wean. Could you talk a little bit more about exactly what does that assessment entail?
Sure. There are standard, what people have called weaning criteria, although that's probably not a good name for it. But it's basically looking at the criteria, the physiologic state of the patient, to see if they are even close to being considered for removal from the ventilator. And these include things like the FiO2. So if they're on 100% oxygen, they're not even ready to consider about that. If they need a very high minute ventilation, they're not going to be ready. If they're delirious still, they may not be ready. If they have secretions that are copious that they cannot handle. And then if they pass those criteria, then you look at what we used to call a weaning trial. Now it's people call it something different, various names, but taking them off the ventilator and putting them on a trial whereby they are breathing on their own to see if they're ready to come off. But the first step is really to force yourself by protocol to determine whether the patient is potentially ready for that. And where we see inappropriately prolonged ventilator time is when the patient isn't recognized as actually being ready when they actually really are.
Excellent. Thank you. One question to sort of go along with that. Do you do this on a daily basis, or is it twice a day that you assess the patient for readiness to wean?
Well, I've never heard of a protocol that does it more than once a day. So I think if you're doing it once a day in a systematic, protocolized way, that is probably the way to go, because there are some resources that are needed to do this, to assess it and to document it. That being said, there are plenty of times where a patient fails that in the morning, things change. You know, they get 40 Lasix and they urinate out 3 liters, and by afternoon I go by and they're different than they were in the morning. And certainly the fact that they failed in the morning wouldn't prevent me from trying in the afternoon, and often that can be successful. But I think the cost-benefit ratio would be such that you would not want to protocolize more than once a day assessments. But that kind of anecdotal story that I just told, which any critical care doc I think would attest to, speaks to the the potential importance of an ICU where there are physicians available seeing the patients on a regular basis, as opposed to one where someone rounds in the morning and never really is available for the patients the rest of the day. Those type of ICUs certainly can work well, but they need a high level of protocolization to work well.
All right, thank you for that answer. We still have a few more minutes, so if you have a question, again, please press *6 on your line. We did have a brief question in chat about whether the presentation would be recorded, and yes, it will be recorded and posted to our website within a few business days, and the link to that recording will be provided in the follow-up email tomorrow. So again, any questions, *6. Alrighty, well, if there are no more questions, I have a few more follow-up announcements. As you close out of this webinar today, you will be automatically directed to our brief evaluation. If you would please fill that out, we greatly appreciate it. Your feedback really does help us plan our future events to make sure we're bringing you topics that are meaningful. Several of you are interested, if you're interested in CEU credit, you must complete that evaluation. If you don't have time to do it right now, the link to the evaluation will be included in the email going out tomorrow, which will also include the link to the recording. The presentation is on the website already if you have not had a chance to download that. And thank you again, Dr. Metersky, and we'll look forward to our next call with everyone. Thank you. Bye, everyone. Thank you, Dr. Metersky. That was outstanding. Thank you.
You're quite welcome.